My job today is a subject I've been studying for many years, and that is to summarize briefly and simply the current status of thinking on macular pigment supplements with respect to age-related macular degeneration. I'd like to start off by just declaring any conflicts of interest. Basically, as you can see, there's no nutraceutical company that exists that I haven't received funding from, either for my research or for talking. But I always insist in any contract that scientific independence and editorial control is maintained by the research group led by myself and John Nolan. So basically, I usually start off by saying the putative protective effect of macular pigment for age-related macular degeneration. Putative is a word that not everybody knows what it means. Putative almost means presumed. But this is the first time I've given this lecture, because it's updated, where I don't have to say the putative protective effect of macular pigment. Because on the 4th of May 2013, the Arid Study was published, and it is a proven protective effect of macular pigment for age-related macular degeneration. It is now proven. And basically, and we'll go through this again slowly, its protective effect, I'm so used to saying putative, its protective effect is attributable to at least one of two mechanisms, which will make sense as I talk. One is it filters blue light before this high-energy, damaging, short-wavelength visible blue light hits the photoreceptors and causes oxidative stress. And secondly, because macular pigment's constituents, lutein, zeaxanthin, and mesozeaxanthin, are antioxidants. So they're just like vitamin C, which means they can gobble up nasty molecules known as free radicals, which cause oxidative stress. And that will all be explained slowly. I'll start off by talking about the two trials that have been published. One is KARMA, and that's a recently published one I was involved with, is a randomized control trial, and the Arid Study, summarizing them very briefly, because we'll be going into the Arid Study in depth after lunch. And then I'll be talking about, and just reminding everybody, that macular pigment is made up of three carotenoids: lutein, zeaxanthin, and mesozeaxanthin. There's three parts of the jigsaw puzzle. All trials, until the one I'll be showing you today, have only involved two of the three carotenoids. So we'll finish off by talking about the MOST AMD trial, which we have conducted, which is a trial containing all three of macular pigment's constituent carotenoids. I'm going to start right at the very beginning, and people have a different way of classifying age-related macular degeneration. I keep it simple, because with my patients, they get so confused about this dry and wet thing. They say, I have the dry type. But if you have the dry type, it could be the nice early AMD, okay, which means there's no problem, or it could be the atrophic, because it's not neovascular. And so you can have a bad dry and a good dry. So I don't use the term dry. I keep it real simple. There's two types of age-related macular degeneration: early macular degeneration and late macular degeneration. Early macular degeneration is drusen and pigmentary changes. And the patients, if you do contrast sensitivity, sure, their vision is down. Yes, glare disability is worse than it would be otherwise. But their visual acuity is normal or near normal. Or there's late age-related macular degeneration. Late age-related macular degeneration is either wet, and that means choroidal neovascularization. So you literally get blood vessels growing from behind the retina, the choroid, under the retina. And how I explain this to my patients is it's a bit like a leak under your carpet. And if you have a leak under your carpet and you stop the leak within a day, the carpet's fine. It might be a slight stain. But if you have a leak under your carpet and you leave it for 2 or 3 weeks, the carpet fibers are all frayed and destroyed. So we treat this wet type with injections, which you've heard of: Lucentis, Avastin, and now Eylea. But that's $25,000 per eye per year, just to stop the eyesight getting worse. So we'd rather never get to late AMD. The other form of late AMD is atrophic. And unlike a leak under your carpet, it's literally suddenly the carpet becomes frayed without anything, and you can see right through to the floor beneath it. And there is no treatment anywhere in the world. This is typically 10% and 90% of late AMDs, okay? But it will vary from country to country. For example, Iceland, it's the opposite. They have loads of atrophic AMD and very little neovascular. But in general, This is the common late form in the UK and Ireland and Western world. So basically, everything we're talking about today is preventing early AMD from becoming any form of the late AMD, because this one we can't treat, and this one we can treat at $25,000 per eye per year. Now, this is early AMD. This is the macula, and all these white dots here, they're called drusen. And patient probably has normal vision, so there's no real problem. But they could go on and get atrophic AMD. This is the atrophic late form, where it's literally wear and tear, and you can see through to the layer beneath it. Or they could get the neovascular late AMD. This we can treat at a cost of $25,000 per eye per year, and you can see that there's blood leaking under the retina, and if we leave that as it is, it'll end up as scar tissue, and vision will be permanently and irreversibly lost. And it's important to remember that when you have untreated or untreatable late AMD, you can see everything except for what you're looking at. So you can't read, you can't recognize faces, you can't watch television, you can't drive. And that's becoming increasingly important, because we're not retiring anymore for 5 years. We're retiring for 30 years. We're having much, much smaller families. And our children are likely to move away to a different town or city, unlike 50 years ago. So you have much less family support. So this will affect your independence. And it also has an enormous socioeconomic impact on the local services. If the person cannot read, recognize faces, watch television, or drive, they need transport to and from for their shopping. They need home help. They need electronic books, you name it. They need the whole works. So it's very important that if there's any way we can either delay the onset of late AMD, slow down the progression of early AMD, or even prevent AMD, not only would it dramatically reduce the suffering of the sufferers, but the unaffordable and growing socioeconomic burden will be addressed. And this is best displayed by this slide. And this is European life expectancy, 1960. It might amaze you to find out that from the time of Jesus Christ until 1840, life expectancy didn't increase. Then Joseph Lister found out about bacteria and the importance of hygiene, and it started increasing dramatically since then. In 1906, the first world census was conducted. So it took 15,000 years of civilization to get to 1 billion people in 1906. 100 years to get to 7 billion. This is an absolute unprecedented explosion that very few people are talking about. Society is not even vaguely ready for the aging population and its implications for healthcare and social welfare. Life expectancy every year increases by 6 weeks. Okay, so we're dealing with an age-related condition here, and if we can delay or prevent the onset, we need to look into that. So now, having explained the background of what we're trying to do, this is really the only sort of sciencey bit that does need some concentration, and it's going to take, I'm going to basically talk you through what oxidative stress is. Oxidative stress is tissue damage by unstable molecules. These unstable molecules are called free radicals. So all it is a molecule without an electron in its outer orbit, an atom, okay? Now, that's very agitated. It wants an electron. So it steals an electron from another molecule. So now there's two problems with that. This molecule, from which it has stolen an electron, is denatured, so it can't carry out whatever it was supposed to do. If it's a photoreceptor, it can't be a photoreceptor. But in addition, now this molecule is missing an electron. So it steals an electron from the next molecule, and you get this chain reaction. So why do we get free radical production? Why do we get these unstable molecules? Well, I'm afraid you cannot drive a car without exhaust fumes. You cannot have a Krebs cycle. You cannot metabolize oxygen. You cannot live without producing free radicals. So it's the cost of doing business with oxygen. Now, an antioxidant is simply a molecule with a spare electron. That's all it is, like vitamin C or vitamin E. So if you have enough vitamin C, and there you have your agitated molecule, it can donate an electron Now it's happy, but vitamin C hasn't turned into a nasty free radical. That's all it is. That's everything you need to know about oxidative stress. Now, how does this relate to the retina? Well, first of all, the retina has the highest oxygen metabolism of any tissue in the mammalian world, any tissue in the mammalian world. But oxidative stress is not just caused by oxygen metabolism. It's also caused by things like smoking or exposure to light. Now, there's only two organs in your body which are exposed to light. They are your skin and your eyes. And this is why you ladies put antioxidant cream on their skin to prevent aging. So what is the evidence? What is the evidence that light causes or contributes to age-related macular degeneration? Well, they've done these experiments in monkeys, and they light-reared and dark-reared monkeys. The light-reared monkeys, after several years, developed AMD. These are normal ambient levels of light. They had darkness at nighttime. And the dark-reared monkeys did not. Okay, so light contributes to AMD. They then repeated the experiment. But this time, what they did was they blocked out the blue wavelengths of light in one group of monkeys, and they allowed all the wavelengths of visible light, just visible light, in the other monkeys. The ones who were exposed to the ambient levels of light, but not blue light, did not get AMD. The ones who were exposed to all the wavelengths of light, including blue light, did get AMD. They then repeated the experiment a third time. And in the third time, the monkeys were reared with all levels of light, all wavelengths of light, but given antioxidants, versus all wavelengths of light, but not given antioxidants. The ones given antioxidants were protected from AMD. So in other words, so blue light, blue, normal visible light, does contribute to age-related macular degeneration. But we can also say that the mechanism whereby it achieves this is through oxidative stress. And we also know this from the Arid study. So how does all this fit in with the genetic background? Well, it fits in perfectly well. So if you have all the bad genes, so you're pre-programmed to get AMD at age 50, but let's choose this example. Let's say you don't have the bad genes, so you're expected to get AMD here at age 80. Well, if you behave yourself, and if you don't smoke and you take supplements, you'd put that back to 100. So it is a genetic disease, but subject to environmental provocation. So we can reconcile those facts, no problem. Now we're going on to the final part of the talk, the trials. So this is why we're here today. There are these substances in nature, and John alluded to them earlier and showed you the nice pictures of the birds. And they're called carotenoids. Carotenoids cannot be made by mammals. There are 600 carotenoids in nature. There's probably more like 700. In a typical diet, there's 50. In blood, there's 22. That should say plasma. In serum, there's 15. But with amazing and exquisite biological selectivity, there's only 3 at your macula. Okay? And amazingly, they're only at your macula. They're not in your retina. So it must be for a purposeful role. This slide tells you everything you need to know about macular pigment. It is yellow. It is only at the macula. Beyond 7 degrees eccentricity, it is optically undetectable. It reaches its peak concentration in the receptor axon layer. And so it blocks out the blue light, because it's yellow, before the blue light hits the photoreceptors, which are here. And that pretty much explains everything you need to know. So why does macular pigment protect against AMD? Well, we've talked about how blue light contributes to AMD and blue visible light. And we know that it's an optical filter because it's located before the blue light hits the photoreceptors, and it's yellow. So it only absorbs blue light. It doesn't absorb anything else. And it doesn't absorb just a little bit of blue light. It absorbs 40% of the blue light. And it's also, as I've said, a powerful antioxidant. And this is best explained in these 2 slides here. Here's a patient who has no macular pigment, and you can have no macular pigment. If you eat no fruit or vegetables for 3 years, you will have none. So that means, A, much more blue light gets through to the photoreceptors and causes oxidative stress. And B, once it does cause oxidative stress, there's no macular pigment to quench it, to satisfy it through its antioxidant properties. Whereas this patient here is supplementing, has loads of macular pigment. So A, much less blue light gets through to cause oxidative stress, and B, even if oxidative stress is induced through oxygen metabolism and other mechanisms, that's fine because you've plenty of readily available and accessible lutein and zeaxanthin to quench, to give an electron to those nasty free radicals here. So the damage to the photoreceptors is not caused. And this whole concept is summarized in a recent review article that we published last year. So now I'm going to talk you through the 4 seminal trials on this subject. The very first one is the Arid Study, and this really got the ball rolling. It was published in 2001. And what it was 3,640 patients aged 55 to 80 years with age-related macular degeneration. And they either got placebo or they got a cocktail of antioxidants. This is just the grades. Grade 4 was they had very bad AMD in one eye, so the other eye was a time bomb, and the other eye was the study eye. Grade 3 was quite severe, but early AMD. These are all earlies. This is mild early AMD, and this is almost no AMD. And they were given vitamin C in very high doses, vitamin E, beta-carotene, zinc, and copper. The only reason they give copper is to stabilize the zinc. Now, what they found was that if you were given zinc and antioxidants, you had a much reduced risk of getting visual loss from age-related macular degeneration, and not only visual loss, but of progressing morphologically, so your retina looked better. But the big problem with AREDS was that it did contain beta-carotene, which has since, including in AREDS 2, been shown to cause lung cancer in smokers, and it's also been shown actually to inhibit the absorption of lutein and zeaxanthin from your gastrointestinal tract. And ideally, the supplement should have contained lutein and zeaxanthin, but at the time, which was 94, when that study was conceived, that simply wasn't commercially available. So now I'm going to go on, but really what the Arid study did was it provided proof of principle. It said, yes, antioxidants are good for age-related macular degeneration. So now I'm going to go on to a very recently published study by our group called the KARMA study. And the KARMA study was supported by Bausch and Lomb. And what it included was, I was one of the principal investigators, as was Usha Chakravarti from Belfast. And there just are conflicts of interest. And it was really designed to investigate the putative, because at the time it was putative, beneficial effects of supplemental lutein and zeaxanthin with co-antioxidants in patients with early age-related macular degeneration. So it was a randomized, placebo-controlled clinical trial, double-masked, parallel group design with a minimum follow-up of 12 months. It was designed so that all participants would have a minimum follow-up of 1 year, and this simply goes through our fallout rate of participants. It's known as a consort diagram. Now, there were 2 groups of eyes. One had late AMD in one eye, but the other eye was the study eye, so they're very high risk. Or they just had early AMD in each eye, and we had to do it this way to give proportionate weighting, because the group 1 eyes are at very high risk of converting to late AMD. What we gave was 12 milligrams of lutein, 2 milligrams of zeaxanthin, and we gave vitamin C, vitamin E, zinc, and copper. And the placebo just consisted of typical placebo contents. And it was divided in 2 tablets. And the outcome measures were best corrected visual acuity, contrast sensitivity. Raman is simply a measure of macular pigment, and fundus photography for grading. We also obviously measured serum lutein and zeaxanthin, and a dietary questionnaire. The primary outcome variable, so the primary outcome, which was very ambitious in retrospect, was visual acuity at 12 months. In other words, did taking the supplement make a difference at 12 months in terms of best corrected visual acuity? But the secondary outcome measures were best corrected visual acuity and contrast sensitivity at any time, so 2 years, 3 years, 4 years into the trial, macular pigment, serum concentrations of lutein and zeaxanthin, and morphological progression, so whether the AMD actually progressed when you took a fundus photograph. And here are the results of the CARMA study published last year in Ophthalmology. After 36 months, there was no visual change in the placebo group, but in the active treatment group, there was a visual improvement. But importantly, is not the difference from baseline, but the differential. So if you were assigned to this active group, did you have a better outcome than if you were assigned to the placebo group? And you can see here, this is the differential, and you had a statistically significantly better chance of having better visual acuity at 3 years if you were given lutein and zeaxanthin supplements versus placebo in this trial. We did not find the same for contrast sensitivity, but macular pigment, which as I say was measured with Raman, showed that in those who were treated, that's the active group, macular pigment stayed increased, whereas it actually decreased significantly. And this was if you were given placebo. So there's no surprise there, because if you have early macular degeneration and if you're not taking supplements, you are going to get loss of photoreceptors, and the macular pigment is housed in the photoreceptors. We also looked at serum lutein, and what we found, and unsurprisingly, was that if you were in the treatment group, your serum lutein increased, whereas thankfully it did not if you were in the placebo group. But more importantly, you had significantly less risk of progression of macular degeneration, say from this to this, if your serum lutein increased, and you had a significantly better chance of better vision if your serum lutein increased. So that was important. Now, and there are the statistics there. So although no beneficial effect was shown in CARMA with respect to the primary outcome measure at the stated endpoint, 12 months, but you wouldn't expect it, secondary outcome measures favored the supplemented group both in terms of better acuity and reduced progression to more severe stages of AMD. Best corrected visual acuity was significantly better if you got the treatment at 36 months. And again, there's no surprise that you won't see a benefit for several years. And higher serum concentrations of lutein were associated with A, slowing down of progression of AMD, and B, better visual acuity. And this was published in Ophthalmology last year in 2 separate papers. One was the secondary outcomes, because they were positive, and the other one was the primary outcomes. Now, we're now going on to the Arid study, which was published, as I say, on the 3rd or 4th of May this year. The Arid study was inspired by Arid 1. Arid 1, as I said, provided proof of concept that if you gave dietary antioxidant supplements to patients with early AMD, you helped them. But it seemed silly that the 2 most biologically relevant antioxidants, which accumulate at the macula, lutein and zeaxanthin, and not only are they antioxidants, but they also absorb blue light before the blue light hits the retina, that they weren't included. And so, therefore, people designed the Arid study, which I'm going to go through very briefly now because we're going through it in detail later. Okay? It was a median of 5 years follow-up. The primary outcome measure was progression to advanced AMD, so from early to either atrophic or neovascular. And the secondary outcome measures included visual acuity, lens opacity. They also looked to see whether cataract was affected, vision change in advanced AMD patients. They also looked at whether eliminating beta-carotene from the supplement affected AMD or vision, or whether reducing the zinc affected AMD or vision. But we'll go through this again slowly and in much more detail after lunch. It's a very complicated trial, and we're not going to go through this slide till after lunch. But long story short, it's very important that everyone knows that everyone in Arid 2 got an Arid 1 formula. So it was not placebo-controlled. So you were allowed to have Arid 1 or Arid 1 without beta-carotene, or Arid 1 with low zinc, or Arid 1 with no beta-carotene and low zinc. Then, and only then, were you randomized to one of the 4 treatment groups as follows. Either lutein, 10 milligrams, and zeaxanthin, 2 milligrams, or omega-3s, or lutein, zeaxanthin, and omega-3s, or a control group, which is not a control group, because everyone was on the Arid 1 formula. But it's so important that, and we'll go through it again this afternoon. I'm just going to fly through it at this point. Now, so all participants of the 5,000, except for 19, as I say, were on the high-dose cocktail of antioxidants. That's the Arid 1 formula. These are limitations of the study. Macular pigment was not measured in this study, except for 150 of the 5,000 subjects. And they also didn't measure glare and contrast sensitivity. Now, the primary outcome, if you remember, was disease progression. And they made and admitted they made a fundamental error. And that was they structured it so that if Arid 1 produced that much risk reduction, that adding lutein and zeaxanthin should have an additive effect. So they were looking for a double effect, which is counterintuitive because antioxidants work synergistically. They're complementary to each other. They're not additive. So it is no surprise that the primary outcome, which was risk of progression to advanced AMD, did not show a benefit. Okay, and we'll go through this in detail this afternoon. I'm not going to go through the Arid's 2 slides now. But briefly, the secondary outcomes showed that there was a significantly reduced risk, 9%, of progression to advanced AMD if you were given lutein and zeaxanthin versus you were not given lutein and zeaxanthin. Also, if you looked at diet, those who had an appalling diet, who were in the lowest quintile, that's this bit here, of lutein and zeaxanthin intake, they benefited massively with a 26% risk reduction in progression to advanced AMD. Also, there was a significant reduction, 18% in risk of progression to advanced AMD for subjects who got lutein and zeaxanthin but did not get beta-carotene, and you'll see why in a few minutes. It turns out that beta-carotene actually inhibits the absorption of lutein and zeaxanthin when compared with subjects receiving an Arid's formulation with beta-carotene. Also, there was a 26% risk reduction of profound visual loss, of catastrophic visual loss, for patients who got lutein and zeaxanthin but not beta-carotene versus patients who got beta-carotene but not lutein and zeaxanthin. So that really is what you want to achieve. You want to avoid a profound visual loss. Beta-carotene was associated with poor absorption of lutein and zeaxanthin. There was a 2-fold increase in lutein and zeaxanthin serum levels, unless you were also getting beta-carotene, in which case that wasn't seen. And also, beta-carotene was associated with increased risk of lung cancer in Arids too. Importantly, omega-3 was found to be of no benefit in any analysis. But it's also very important that supplementation with lutein, zeaxanthin, omega-3 fatty acids, or beta-carotene had no significant effect on mortality. Now, I'm going on to the last bit. So just to summarize so far, early AMD is something we can live with, and we want to prevent it going to late AMD. There's a very strong biological plausible rationale, backed up by evidence, that macular pigment will protect against it. It's no longer a hypothesis, really. The KARMA study showed an improvement in benefit. The AREDS 1 study showed that proof of principle that antioxidants were good for you. And AREDS 2 study has shown that if you give lutein and zeaxanthin to early AMD patients versus no lutein and zeaxanthin, it's advantageous. So that's where we are. So now we want to see what impact the third macular carotenoid has, because AREDS 2 did not include mesozeaxanthin. So we've just conducted a study called the MOST AMD study, and there were 3 groups of people. Group 1 had high lutein with a little bit of zeaxanthin. Group 2 had 10 milligrams of meso, 10 milligrams of lutein, and 2 milligrams of zeaxanthin. So that's the MacuShield formula. And group 3 had high mesozeaxanthin with very little lutein and zeaxanthin. Unlike AREDS 2, And because it's a small trial with short follow-up, our outcome measures are appropriate to such a design. So we're really looking at macular pigment as an outcome measure, visual performance, and disease progression, macular morphology. But ultimately, we've only 2-year data today. We won't see any change there until you follow them up for 3 or 4 years. So as I say, we measured macular pigment with heterochromatic flicker photometry. Corrected distance visual acuity was measured with the ETDRS chart, and contrast sensitivity using published techniques. Macular grading of AMD was done at the University of Wisconsin using the WARMGS grading system, and it was done in a blind fashion. 67 subjects recruited, 52 completed 12-month analysis, and 50 completing the 2-year analysis. And the intervention groups were comparable in terms of baseline variables, including contrast sensitivity, visual acuity, etc. So now for the results. At 12 months, if you gave the high lutein group, in the high lutein group, there was an increase in macular pigment. Whatever's in bold print is statistically significant. There was an increase in macular pigment, but only at 1 eccentricity. If you gave MacuShield with the 10-10-2 formula, you had an increase in macular pigment at all 4 eccentricities. If you gave the high mesozeaxanthin one, you also had an increase in macular pigment at all 4 eccentricities. Now, at 24 months, the lutein was a slow catcher-upper, but it did catch up at 3 of the 4 eccentricities. It still didn't get it centrally. The MacuShield increased macular pigment at each and every eccentricity, but the high mesozeaxanthin didn't. So it does seem that in terms of maintenance of augmented macular pigment, that the 10-10-2 formula does seem to be superior. We're now looking at contrast sensitivity in these 3 groups of patients. So if you were given the high lutein formula, you did notice at low spatial frequencies an increase in contrast sensitivity. And it's probably not surprising at low contrast sensitivities, because that'll be off-center because it's lutein, which is the dominant carotenoid in the peripheral macula. We also found it at those eccentricities for the MacuShield group. But if you were given the high mesozeaxanthin group, and again, unsurprisingly, it was the higher spatial frequencies, which means smaller target sizes, where the contrast sensitivity improvements were statistically significant. Now we're going to look at the same data, but at 2 years. And at 2 years, unfortunately, the lutein group lost its significance, so it wasn't significantly improved in contrast sensitivity. The MacuShield group retained its significance at just 1 eccentricity, though, whereas the high mesozeaxanthin group also lost a little bit at 1 eccentricity, but it did show improved contrast sensitivity at 3 of the 4 eccentricities. So now we're going to look at macular morphology, so fundus grading, and this is quite interesting. Now, I do have to point out, and it should be with full appreciation, that this is only 2-year data, okay? So you wouldn't expect massive progression in such a small number of patients. But let's look at what we had. 79%, 80% had no clinically meaningful change. They were in 7 grades of age-related macular degeneration graded by the Wisconsin Grading Center. If they didn't move by plus or minus 1, by more than plus or minus 1, it was considered stable. So 79% at 12 months, had no clinically meaningful change. 11% exhibited progression. That means they leapfrogged at least 1 grade of age-related macular degeneration, and 10% exhibited an improvement. But between the intervention groups, there was no significant difference. Now, the same stuff at 24 months. 90% showed no clinically meaningful change. Only 4% exhibited progression, so it's as if it's taking a while to work. And 6% exhibited improvement. But again, there was no significant difference between the intervention groups in terms of morphological progression, stabilization, or regression. It is important to say that in this same population, Southeastern Ireland, where we recruited these patients, where we did the Karma study, which I've talked you through, we had a 12% progression to advanced AMD at 2 years. If that had happened here, 12% of 50 subjects would have been about 10 subjects, and no subject progressed to advanced AMD. Now, I can't hang my hat on that and say, but it is worth pointing out. We have some of our 3-year data, 36-month data. We haven't analyzed it. I'm just going to show you one picture. This is a patient at 36 months, and they have a soft druze there, graded by Wisconsin in a blind fashion, and it was grade 4. And a soft druze is actually a bad thing, because that is at high risk of getting neovascularization. At 36 months, it had completely disappeared, and more importantly, it had disappeared without leaving atrophic changes which will affect vision. So there's some cause for optimism that, and this patient was actually on the MacuShield formulation. There is some cause for optimism that it may slow down disease progression. And this is just the macular pigment measurements done here. You can see they started with the central dip, but they lost the central dip. So the main findings of the MOST AMD study are that macular pigment optical density can be increased at all 4 eccentricities at 12 and 24 months, but only if you use the 10-10-2 formula. If you want contrast sensitivity to be improved at 12 and 24 months, you do need a supplement which contains mesozeaxanthin. There is cause for optimism, but it's too early to make any firm statements that it does slow down the progression of macular degeneration. We'll have to wait till the 36-month data. The strengths of this study are obviously that it includes mesozeaxanthin for the first time. The weaknesses are that it's a small study and only 24 months follow-up, but that weakness will be addressed by a trial we've just started in Waterford called the Crest Study. And this is a randomized controlled trial of the Arid 2 formula versus the Arid 2 formula with mesozeaxanthin. It was quite fortuitous because if you remember, the dose of lutein and zeaxanthin in Arid 2 was 10 milligrams of lutein and 2 milligrams of zeaxanthin. The dose of MacuShield is 10 milligrams of mesozeaxanthin, 10 milligrams of lutein, and 2 milligrams of zeaxanthin. So the only difference is the 10 milligrams of mesozeaxanthin. So basically what we're doing with this trial is comparing Arid 2, which is proven to work, with Arid 2 plus MZ, which, given the aforementioned discussion and the talks that John gave this morning, is more likely to be of benefit because you're providing all 3 parts of the jigsaw puzzle. So just in conclusion, it does look like, at last, we're getting to grips with manipulating nutrition to slow down the progression of the most common cause of blindness in the Western world. It's very important that we continue to research all avenues in this, including all 3 macular carotenoids. It's now a proven protective effect of macular pigment augmentation and supplementation with macular pigment's constituent carotenoids for progression of age-related macular degeneration. It would seem wise to include all 3 macular carotenoids, and that's what we're looking into now. However, we do know that inclusion of all 3 of macular pigment's carotenoids does result in better augmentation of macular pigment than alternative formula and better improvements in contrast sensitivity. I'd like to acknowledge all my co-workers before finishing up. John Nolan, who have you met, Kwadwo Akufo, who's doing the Crest AMD study, Alan Howard, who has been instrumental in scientific advice, etc. This is all our research group recently. And as John said earlier, we're very lucky. We seem to have a state-of-the-art vision facility in rural Ireland, which is quite an aberration. Katie Marr, Sarah O'Regan, that's me again, Jim Stack and Rachel Moran, Christine Leamy, Sarah Saber-Pickert, Niamh, Kate, Claire, Kwadwo again, and Jessica. Thank you very much. Any questions?
What's the mechanism for lipofuscin or drusen actually disappearing with supplementation? You showed a slide there with the soft drusen that disappeared.
Yeah,
How can that be?
it's a very, very good question. I mean, where does it go? Where does it go without causing problems? Don't know.
Fair enough.
I mean, presumably, if a drusen disappears, a drusen is debris, and the debris is pumped out through the retinal pigment epithelium and a Bruch's membrane. In theory, whatever mechanism these antioxidants are doing, it could be improving the pump mechanism of the debris through the retinal pigment epithelium. And maybe the big problem with age-related macular degeneration is a thickened Bruch's membrane, so the debris can't be removed. So presumably, and there is some in vitro evidence to say that it improves, that lutein and zeaxanthin supplements improve the ion something balance, which allows pumping to work more effectively, but I don't know.
Just to point out on the morphology data that was shown, one of the limitations, of course, of the study is there's no placebo group, and you have to be very careful when you're comparing to another study, their placebo group, but it's also sensible to have a look at it. And I just think to echo the point that Stephen mentioned, and that is, you know, if you look at what's normal, when we look at the Carmel placebo group, we had 50% of people progress not to an end stage, but to a level that was considered meaningful, more than 2 grades. We're now at 2 years with this data, and with this formulation, we've essentially stabilized the morphology in over 90% of people. And what's even more interesting is that if you look at how things shifted from 12 months to 24 months, it's much higher in terms of stabilization. So while there's not a suggestion yet of direct improvement, people are moving in the right direction. So it is fingers crossed on that, and we wait to see what happens in Crest on it. The other point I'd like to make is, if we look at the Karma study, again, because Stephen summarized the results of the Karma study, the conclusion from that was that the primary outcome wasn't hit, it wasn't met. The supplementation essentially didn't work, if you're to look at it cleanly. Where you did get a positive effect was when you looked at lutein response. In other words, what happened in the serum, so who did get that response, and subsequently in the macula. So the point is, I think this data clearly shows the issue around non-responders. And I think I was speaking to someone at break time there about potential non-responders and the concerns around that. And what we see is that there's much, much less in terms of non-responders when you have that formulation that contains the 3 carotenoids. And it's possible and likely that they may even facilitate uptake by working together. We talk about the synergistic effect. And so that's just a point I'd like to make.
Hi, thanks, Stephen. Just a point that Bill made there. I think it would be nice to see some OCT data, you know, along with that. I've seen certainly drusen disappearing where in patients, but when I look at the OCT, it does tell me a different picture. But my question was, what's your opinion on yellow IOLs? We're having in Scotland, certainly, privately, most people now getting yellow IOLs, and the NHS people not. And just your opinion on that?
Yeah. Myself and Jessica, that's the girl sitting beside you there, have just written a review article on yellow IOLs, and this is my view on it. There's no doubt that yellow IOLs, for the same reason that macular pigment, will help with glare disability, will help with contrast sensitivity, will help with photostress, okay? But why deprive the entire retina of visible blue light when macular pigment is there to do exactly that? It's not called retinal pigment, it's called macular pigment for a very specific reason. And I've no doubt that we do need, and it's proven that blue filtering IOLs, yellow IOLs, although they may confer an advantage centrally, that's never been shown where they've measured macular pigment. But why deprive 100% of the retina because you want to confer an advantage just at the very center, when you could just augment your macular pigment and get all that in a much healthier way, because blue light is necessary for scotopic vision. Blue light filtering IOLs have been shown to reduce scotopic vision. And in addition, they may affect the sleep cycle, because blue light is important for the sleep cycle. The way I say it is, I used to use blue light filtering IOLs, and I stopped. And the only reason I stopped was because the patients weren't happy. It's that simple. So I've had a patient come in, and I did one eye, and then the other eye, and they were both 6/6, but they always preferred the eye without the blue light filtering intraocular lens. And in my view, how do you diagnose cataract? You put them on the slit lamp and you see a yellow lens and you say, oh, you've cataract, I'm going to take it out. And I'm going to replace it with a yellow lens? It just makes no sense. It makes no sense. So I've stopped using them for those reasons, and I believe that's why macular pigment is there. That's why macular pigment is there. It's to give you the blue light, pre-receptor blue light filtration, so you reduce chromatic aberration, glare disability, photo stress, all those wonderful things, blue haze, everything. But you shouldn't deprive your entire retina of it, just the central retina.
Can I say then, in your Crest study, are you going to have a subgroup where, as you know, patients, when you do the IOLs, when you put in clear IOLs, the first thing they always say is, doctor, it's just so much brighter, right? But you blast the retina suddenly with blue light, whereas before it's been filtering it all out. Do you then think that these patients are at more risk than patients who have just got natural age-related changes, a 70-year-old with still their own lens versus a 70-year-old with a new IOL?
Well, the blue light mechanism of damage is very chronic and cumulative. So let's say the patient is typically 67 years of age. So they've had variable amounts of blue light going into the retina for 67 years. And then you take the cataract out. Now, you're still blocking out ultraviolet light, even with the non-blue light filtering intraocular lenses. So in my view, they're getting no more blue light than they were at, say, age 30. So you are restoring youthful vision. If you want to protect against them, macular pigment, that's what it's there for. But don't deprive the peripheral retina of that blue light. That's my view. Okay. Have I answered your question?
Yeah, I think so. It was mainly about if you put in a white IOL and you put in a clear IOL, do you blast that retina with more blue light than
You mean, I suppose what you're saying is that they've sort of, because of their yellow crystalline cataractus lens, that less light has been going into their eye for several years, and now you are overnight changing that, and does that have an impact on a sudden increase in luminance of the retina? There's no study to suggest that it does. There's a hypothesis that it might, but there's no study, and it would be a study that's almost impossible to do because you'd have to correct for how much blue light they were getting until the day of surgery, and they'd all be different ages, so I think there's no evidence, there's no empirical evidence.
It's just anecdotally, you always see sometimes patients that had it a few years ago and suddenly their macular degeneration gets a lot worse.
Yeah.
But it's anecdotal, you're right.
It is anecdotal, and there has been a recently published meta-analysis of whether cataract surgery does increase risk of progression of macular degeneration, and it does, but minimally. Okay.
Thank you very much. Thank you.
We've been supplying MacuShield now for several years, and we see some people respond very quickly to it, and some people don't respond at all. Now, you've been saying that the beta-carotene is a blocker, in effect, and I wonder, are there other foodstuffs or elements that could block the absorption? And if so, is there any research work being done in that field?
So it's a very good question. The question is, so if you're taking beta-carotene supplements, now that we know they prevent absorption of lutein and zeaxanthin, other than beta-carotene, is there anything else? I don't know. I don't know. Does anyone know that?
I think the point the gentleman's making is that he's trying to find a reason why his patient is not responding, and now he's wondering, is it possible that they may have been on another cocktail of antioxidants that would have affected the absorption? And that is possible, I would think.
But beta-carotene, I think, is not popular anymore for all the reasons of lung cancer anyway. Yeah. So I'm not sure if many commercially available supplements still contain beta-carotene. Yeah. I don't know. Does Centrum still contain beta-carotene? Does it?
Does, yeah.
Okay.
Yeah, the standard multivitamin still contains beta-carotene.
Okay.
Yeah. Just another point on Scott's, I think we need to, about yellow lenses versus macular pigment. You do get the optical benefit with yellow lenses, but you don't get that antioxidant benefit. Isn't that right, Stephen? I mean, this is something I've heard you discuss before, so I think you need to keep that in consideration as well. So there's a double sword protective effect. So yes, yellow lenses may help with filtration, but you do not get that antioxidant benefit.
My question, well, it's a comment more than a question. With regard to starting a patient on a supplement, I mean, I have MacuShield in my stock. When we start to see a cataract developing, generally speaking, it takes about 10 years from the initial viewing to when that lens needs removing. So if we recommend that they start to take a supplement at that point in time, is that going to give them greater benefit, or is there an optimum time that they should start to supplement?
Well, intuitively, I think it would. I mean, you would like to protect the photoreceptors before they're damaged. So
the earlier the better.
So the earlier the better.
Okay.
I mean, I wouldn't think 30-year-olds would benefit, but I think
I say to my patients, I've seen a few people with cataracts before the age of 60.
Yeah.
But my line that comes straight out of my head is if I see somebody under the age of 60 with cataract, that's unusual, but it is very normal to see some degree of cataract in a 60-plus.
Yeah.
So that would seem to me to be the good
and
good
I would
time.
agree with that, and that's what I do to my patients. Because
Okay,
not
time
only,
I started then.
not only for that reason, but also because if they have a bit of cataract, they're getting a bit of glare. And they're getting a bit of glare disability, aren't they?
Yeah.
Even if their vision acuity is fine. So for that reason also, they will notice a visual advantage within a few months.
Yeah. So speaking personally then, I've noticed from the age of 20-something that my two eyes see colours slightly differently. So what would be the explanation for that? Would that be to do with the lenses, or?
I don't know, I'd have to examine you.
Okay. Well, it's never been commented on before, but, I'm thinking with regard to what you've said, that there may well be some difference in the macular pigment levels in both
there
my
could
eyes.
be. In general, macular pigment is very symmetrical. Yeah, in general. And we've even looked at dominant versus non-dominant eyes. So in general, macular pigment it's rarely asymmetric.
I know that I can wink with one eye, but not with the other. I'll have to test that one. Thank you.
In Germany, they actually, when a patient is set up for cataract surgery, they typically now give a lutein supplement 6 months prior to the surgery. So I think that's consistent with what you're saying. I have a question over here.
2 questions. One, just an observation. So carrots contain beta-carotene, so carrots are bad for your eyes?
Well, they do contain beta-carotene, and I think we can only say beta-carotene supplements are bad for you. I don't think you can say beta-carotene is bad for you.
Right. And another question about, you probably know or have heard of a laser that John Marshall's been working on, the 2RT
That's right.
Retinol Rejuvenation Therapy LX, which people are claiming possibly rejuvenates the RPE.
That's right. It's gone quiet. I haven't heard anything in the last year.
Any comments
No, I
or
mean,
observations?
basically, my understanding is that the laser stimulates Bruch's membrane and stimulates the retinal pigment epithelium to do its job better. But it's gone. It was very loud 2 years ago, but I haven't heard anything the last 24 months, so I don't know if it's still...
I got an email from John Marshall, and he just said we're recalibrating the laser.
Just one more quickie. We've been trying to get a story on the LX laser and also that photonics flashing light mask for reducing, and both of them refuse to give out any data at the moment, which is always eminently suspicious.
Okay.
But my question was just really relating to earlier as well. All the studies are very much supplementation once maculopathy is established, and I think there have been meta-analyses before showing no proven benefit in supplementation in younger healthies. Is that a fair point? And secondly, should we be giving blue light cut-off filters to all kiddies with big pupils and clear crystalline lenses, bearing in mind it's a cumulative photooxidative effect?
It's a good question, especially since people are now going to live to be 100, so they're going to be exposed to a lot of blue light. What was the first question again?
Well, the first question was, then is it true that you shouldn't be recommending supplementation to, say, a 30-year-old? You should just tell them to stop smoking. And secondly, should we give sunglasses to everybody that moves, especially youngsters?
Yeah, well,
And boost profits? Oh,
Yeah.
no.
well, I mean, the answer to that question, what you're really getting at is all these studies are people with established disease. Whereas what's really interesting is, what about people who don't have disease? Can we reduce their risk of developing it or make it less severe if it does develop?
And there has been evidence to suggest no impact, or am I wrong there?
Well, we're the first people. We've just done, there's a study in Ireland called the TILDE, the Irish Longitudinal Study of Aging. I think there's a poster on it downstairs today, and it's well worth looking at. That's 5,000 randomly selected subjects, all aged over 55 years. And they've already had all their tests done, macular pigment measured, fundus photographs graded, and their serum samples taken for lutein and zeaxanthin, and Rachel is actually analysing them as we speak. We've just applied for funding for the 5-year follow-up. So for the first time ever, we will be able to see whether baseline serum concentrations of lutein and zeaxanthin and or baseline macular pigment levels relate to risk of developing AMD in normal people who at baseline did not have AMD, or progression of AMD in the 6.5% who did have AMD at baseline. And that really is the only way of answering that question, because intervening is itself artificial, isn't it? What we really want to see is, does macular pigment relate to risk of disease or risk of disease progression in the absence of supplementation? Because if it does, well then, public health measures would need to be considered. Because if we can push back this disease onset by 8 years, the exchequer will save so much money in every country.
That would be massive. I mean, if you
that would be massive. So we are addressing that. I don't think that sunglasses are essential. I mean, a healthy diet for young people is what I would say. But I do think that once we hit our 40s, that unless you live a very, very healthy lifestyle and a wheelbarrow of fruit and veg every day, to get your macular pigment levels up, I do think you need to supplement.
And Bill, on that, I'm not sure, you missed the very early lecture this morning, but that's exactly what we were speaking about. And I think if you look at the literature on that, it's actually far more conclusive that visual function can be enhanced. That research question has been asked and now answered. So I think a clear review of the literature shows, I know Stuart's in front of you there, he was one of the first to look at this in terms of visual function. And so I think we're clear that it enhances visual function. The Arid 2 has, I suppose, closed the debate on whether AMD progression can be reduced. So, but I think the first one is definitely clearer than you may have suggested there. Sure. That'd be my view.
Okay, thanks.
Is that it?